what is your feelings on, and this was brought up to me by a colleague, and I've been talking to Warren Joseph about this.
Yeah,
We've got some archaic research on osteomyelitis with what, 6 to 8 weeks of IV antibiotics, or
right, right.
um, what has been your thought process? And obviously, debridement is a part of certain things when it gets to a certain stage, but
Yeah,
maybe kind of give me what you're seeing,
yeah.
and also any research that I may not be aware of that has a different spin on the new norm for how long antibiotics with diabetic foot,
Well,
as we get into bone especially.
yeah. So if we're talking about specifically about osteo, I think people overtreat it. So I think in many cases, it's look, osteomyelitis is important, but it is not that big a deal. It doesn't wake you up at night. Very few osteos become raging, rip-roaring, necrotizing soft tissue infections. Osteo is, you usually have time to react. You don't need to go bounding into the OR at 2:30 in the morning. Uh, it's just that's what, necrotizing infections do, will wake you up, not this. So we often will make a really big deal about this. We say we have to cut something off. And sometimes you do if there's just no bone left, if it's all totally destroyed, but very seldom do you have to cut a whole leg off because of osteomyelitis, right? I mean, it's just not, it's just not true. But we can do targeted surgery where we resect the bone, and then balance the patient, through either, through soft tissue balancing and also from bone balancing to try to spread that force out over a larger unit area. But as far as treating osteo, people can treat some osteo now to suppression. And one of my really close friends, you ought to have him on this show, is Jose Luis Lazaro Martinez from Madrid, from the Complutense, and he's done a tremendous amount of work with with one of his with one of my other friends who's from Gran Canaria, and Javier Aragon. But they've shown, pretty conclusively that you can treat some patients to suppression, and you can just do isolated resections and get very good results.
How are you generally mapping out your procedures? You've done X-rays. Let's say
Yeah,
you have the mid shaft of a metatarsal that is necrotic. It's a submet 2 or 3 ulcer. What are you doing generally with your cases? What tests are you ordering after your initial X-rays and your clinical exam? You probe to bone on the
yeah,
metatarsal heads. What next?
yeah. Well, I think
In
so.
your algorithm anyway.
Yeah, well, I'll just say that I think that very often I think, one of my favorite acronyms is victim of modern imaging technology, or vomit. And I say we got a vomit consult or something or other. And how many of us have gotten these? My friends in vascular surgery get them all the time. They get to say they got an MRI of or something of the carotid showing 90% stenosis in an asymptomatic patient. How are you going to treat it? For us, very often it's osteo, maybe on an MR, and there might be some osteo. Clinical correlation is important. And so then you go down with this vomit consult, you go down this diagnostic and, God forbid, a therapeutic rabbit hole, and you often are over-treating patients. So I am a notorious underutilizer of tests. I mean, the time I use a test, like an imaging test, is when I am going to say, if this, then this. And so I may get an MR to help if I'm concerned about maybe retained soft tissue infection or an abscess, or if I want to see the extent of of osteo